Good afternoon, ladies and gentlemen, and welcome to this session, which we're just going to kick off now. It's Tuberculosis in the Time of HIV. I'm Robin Wood from the University of Cape Town, South Africa, and my co-chair is Diane Havlier from UCSF. We've got 6 presentations this afternoon and one introductory session, and we'll start off with that. It's Mariki Wainrox, who was Chief of Staff at the Global Fund to fight AIDS and malaria, now Interim Executive Director of the Global Fund, and also Deputy Director of Social Development Department in the Ministry of Foreign Affairs in the Netherlands. So some introductory comments from you, Mariki. Thank you.
Thank you, Robin. And did you forget to mention tuberculosis in the Global Fund to fight AIDS, tuberculosis and malaria? I thought I didn't hear it. No, thank you very much. And I think, especially for this audience, there's really don't need to explain how strongly HIV and TB are correlated. And TB is the major killer of people living with HIV. And according to 2015 WHO data, the mortality from TB among people living with HIV was twice that compared to people living without HIV. So it's very strongly associated. And that's really unacceptable because HIV-associated TB is preventable and curable. And yet it's still a significant challenge. So how do we deal with that? In the Global Fund, we recognize those interrelations very early on. So countries were encouraged to submit joint proposals, and the uptake was not very good. So then we strongly encouraged countries to do it, and still the uptake was not very good because many countries thought it's the right thing to do, but too complex in our situation. So now for the countries with high co-infection rates, it's mandatory to develop a joint concept note combining HIV and TB. We've seen some very good progress of countries really implementing joint programs, but also still too many countries that develop a joint proposal, but when it comes to implementation, cut it in 2 pieces and implement separately. And there's still too many barriers, and I hope this session will really give some real-time country-level experiences of how these barriers can be addressed. And it's really needed because close to 60% of the estimated people living with HIV who have TB are not reported as linked to care, so they are missing. And there's too many countries that have high levels of co-infection that do not have policies on key interventions such as TB preventative therapy. And if they have policies, far too often they do not implement them. We're simply missing too many cases. We miss too many opportunities for integration, and that comes at a cost in terms of human suffering that's simply unacceptable. So we have to move. It's basically 2 different communities that have to come together for a common goal and looking at the person and move out of silos. So I'm really looking forward. I was having a sneak preview at the presenters and their presentations. And these are presentations from countries with high and extreme rates of co-infection. And hopefully will learn us a lot of lessons on how we can really move forward on this very important agenda. So I leave it at that because I just want to take time for the presentations.
Thank you very much. We'll move on to our first presentation, which is from Annabelle Badley. She's worked in the TB, HIV and Community Engagement Unit of the WHO since 2010, and she's going to be presenting data on the gaps and opportunities in policy and practice in 20 countries with the highest burden of HIV-associated TB. Thank you.
Okay, thank you very much. Thank you very much, firstly, to the organisers for allowing me to present. I'm presenting on behalf of my colleagues. It's a joint effort from the Global TB Programme and the HIV Department at WHO. And as Marika said, TB obviously is the highest cause of morbidity and mortality amongst people living with HIV. In 2015, Rishi Gupta and colleagues came up with a meta-analysis and systematic literature review of autopsy studies amongst people who died from HIV, and they found 40% prevalence of TB, and almost half of which had been undetected prior to death. So that means we really need to focus in on where the gaps are in policy and practice to improve our focus and to really reduce this preventable mortality. So during our study, we took 20 countries with the highest number of estimated HIV-positive incident cases in 2015. And together, those countries accounted for close to 28 million people living with HIV, 1 million of which developed TB in 2015, and just over 400,000 actually reached care. And they accounted, these countries, for 86% of the burden of HIV-associated TB globally. So the data we used was data submitted by countries on TB, HIV, and HIV-related TB to WHO and UNAIDS on case detection, treatment, and prevention of HIV-associated TB for the 2015 cohort, and the treatment outcomes according to HIV status. In addition, a standardized data extraction tool was developed to assess a gap in analysis of policy and implementation. So you can see from this slide, which shows the unfavorable outcomes, the blue bars relate to HIV positives, and the red bars are HIV negative, that there's a clear discrepancy in access to care, and it's inequitable. Clearly, shows that there is inequitable access to healthcare. So people living with HIV were 3 times more likely to die during their TB treatment than HIV-negative TB patients. And you can also see that loss to follow-up is much higher as well, and this could be masking more HIV deaths. So when we look at case detection, similar to what Marika was saying, globally 57% of estimated HIV positive incident TB cases were not detected in 2015. It was the same across these countries. And this ranged from 95% not detected in Indonesia, and 27% in Kenya. And that accounted for close to 600,000 missing cases. So looking at HIV testing, again, there's quite a bit of discrepancy. One might expect in the concentrated epidemics slightly higher percentages not tested, but you can see that in Thailand, in fact, close to 100% were tested for HIV, as in many of the African countries. But in Angola, 77% not tested for HIV, and in Indonesia, 89%. And this accounted really in total for close to 1.5 million cases in care without known status, which is immense opportunity and really could be addressed. Now, looking at access to expert as a diagnostic test for TB, we can see from this chart the countries in red are countries that reported no policy. Excuse me. So they reported to WHO that they did not have a policy on expert MTB-RIF for people living with HIV. And the blue bars refer to countries that do have a policy. And there is a slight discrepancy here because obviously Angola says that it has a policy, reports a policy on MTB-RIF for people living with HIV, but it only has one site that has experts, so that's obviously not possible. And you can see in China, they've got quite a high number of expert machines. They're used specifically for rifampicin-resistant testing. Then for notified cases on ART, again, there's a big variability. 5% not given ART in Kenya and Malawi versus 79% in Indonesia. Angola did not report any data on ART. So in the 19 reporting countries, close to 80,000 people in care known to be HIV positive were not provided with ART, were not reported having ART. Digging down deeper, we reviewed Global Fund concept notes, and a number of these countries actually reported having stockouts of HIV testing kits and ARVs. And you can see here the countries with the white lettering reported stockouts of both HIV testing kits and ARVs, and the green countries just one of each, one of the other. I mean, this is obviously not going to help access and scale up of these interventions. For TB preventive treatment, you can see this graph. The grey bars shockingly represent the countries where no data are reported. And you can see also very high variability. So in reporting countries, 98% of patients newly enrolled in care in Indonesia did not receive IPT versus 21% in Malawi. And again, digging down deeper, interestingly enough, all these 20 countries have a policy on TB preventive treatment for people living with HIV. But looking at program documents, 14 of them actually implement it, and only 10 reported to WHO those started on IPT. 6 of these countries also reported stockouts. And just to add, those stockouts of IPT also create a knock-on effect, as you can see here. There's a resistance by staff to initiate IPT, and this was found in reviews of concept notes and program reviews. Staff are worried about initiating IPT for fear of future stockouts. Anyway, these are further details of bottlenecks identified during the program and review, policy review, and review of Global Fund concept notes. And you can see that there are a number of issues that are also cross-cutting health system issues, like that affect HR, human resource capacity building, recording and reporting, as well as joint planning and decentralization of services. So to conclude, there were considerable gaps and opportunities identified. Decentralization and strategic integration of HIV and TB services will be crucial for bridging the case detection and treatment gaps. And health system barriers, recording and reporting, procurement, supply management, and human resources really need to be addressed to ensure functional integration and patient follow-up. And of course, further research will be needed to identify and address exactly where the gaps lie in implementation and reporting, as well as quality and timeliness of delivery. Thanks very much.
Thank you, Annabelle. Paper's open for questions. You could just give your name and affiliation and then the question.
Maybe while people are walking up to the mic, Annabelle, first, this is an amazingly important study. Thank you for providing some insight into why we're falling short of our targets. Just thank you for bringing out the problem of stockouts. That's very, very important, and we certainly need advocacy on that. One, thinking about 2 things that you reported. One is, we want to prevent these, I'm thinking about TB mortality. We want to prevent the cases if we can. We have to focus beyond just people starting ART that need IPT, okay? So in the capture of the data, I think that that's very important. And then secondly, and I will keep harping on this until whenever, is that it's not, people are dying. Like for ART, they have to start it, particularly with the low T cells, rapidly. And we should be keeping track and holding programs or helping country programs reach the targets that evidence tells us that it will prevent deaths. So more comments than anything, but thank you.
I'd just like to respond to that, actually. The data that we've looked at has been reported at a global level, but there are actually indicators, national core indicators that WHO recommends for identifying all those issues in the TB cascade chain, as well as timing of ART initiation after TB treatment, and also completion of IPT and all those quality indicators. And so it'll be very important for countries to use those indicators to monitor and to assess the quality of care.
Thank you. We have a question over there.
Thank you. It's Charlotte Watts from DFID. I was wanting to pick up on the issue of the cascade a little bit more, because you're talking now about the TB cascade. Clearly, we all know about the HIV cascade, and surely we should be bringing that thinking together somehow. And I'm just interested to know if there's work to really do that, to do that.
That's a very, very good point. In fact, WHO is coming out with a Cascade Manual for HIV, and we've made sure that TB is very well ensconced in that, including there's a little cascade of case detection versus IPT, in other words, of those newly enrolled in care who are case detected with TB and who are put on IPT, and one plus the other should equal newly enrolled in care. And we're introducing a couple of cascades within the HIV programs documents. So so hopefully that should be taken up.
Thank you very much, Annabelle. Second presentation is from Tyler Brown, trained at Columbia University Medical Center and is currently an ID fellow at Mass General Hospital in Boston. And he will be presenting on genomic epidemiology of extensively drug-resistant tuberculosis in KwaZulu-Natal, South Africa, the demographic expansion and genetic determinants of epidemiologic success of the bug in a high HIV prevalence setting.
Excellent. Good afternoon, everyone. Thank you for coming. Let's jump right in. Extensively drug-resistant tuberculosis poses a major threat to global TB control. Treatment for resistant infections is costly. The drugs used for treatment have significant side effects, and the case mortality associated with extensively drug-resistant mortality ranges between 50 and 80%. For reference, we define extensively drug-resistant TB as resistance to isoniazid, rifampin, as well as the fluoroquinolones and the second-line injectables, which includes kanamycin and streptomycin. The first XDR isolate from KwaZulu-Natal was identified in 2001. We know that this particular isolate evolved from a well-described multi-drug-resistant strain called LAM4 KZN. I highlight that isolate as one to remember and one that we'll talk about quite a bit in this presentation. LAM4 KZN was responsible for a high mortality, widely publicized outbreak among hospitalized HIV patients in Tugela Ferry, KwaZulu-Natal in 2005, 2006. And speaking of HIV, of course, important to underscore that the HIV prevalence in antenatal clinics in KwaZulu-Natal ranges between 30 and 45%, which is higher than most of the rest of South Africa. The incidence of xdr-Tb in KwaZulu-Natal ranges is about 3.5 cases per 100,000. We know that these cases are geographically widespread across the province, and we know that the majority of new XDR cases are due to transmission person to person rather than de novo acquisition of drug resistance while on treatment. Our work sought to address three primary questions regarding XDR-Tb in KwaZulu-Natal KZN. First, when did XDR-Tb emerge? And what was the extent of transmission in the community before the Tugela Ferry outbreak? In other words, was Tugela Ferry a sentinel event for already ongoing transmission in the community, or was it an initiating event for widespread community transmission that would occur later? Second, what pathogen-specific biological factors may have contributed to the emergence and spread of XDR-Tb in KZN? And last, what did high rates of HIV co-infection have to do with all of this? So our approach to these questions used whole genome sequence data to reconstruct the evolutionary history of XDR-Tb, and with knowledge of that evolutionary history, make inferences about the epidemiological history. To do this, we obtained whole genome sequencing for 296 tuberculosis clinical isolates collected in KwaZulu-Natal from 1994 to 2014. We then used Bayesian evolutionary analysis, which I'll talk about a bit more in a second, to infer the dates of acquisition of important drug resistance mutations. We also used Bayesian skyline analysis, again, I'll talk about this in some detail, to estimate the size of the bacterial population going back in time. An example of these methods from the HIV world, this is a very nice paper that used Bayesian phylogenetic analysis to reconstruct the history of HIV in North America and estimate when HIV was introduced into North America, specifically New York City. These authors also used Bayesian skyline data to estimate the size of the HIV viral population going back in time. And here we're going to use that same method to estimate the size of the xdr-Tb population size going back in time. For all of these analysis, like these authors, we used a software package called Beast. So to get started on our results, this is a phylogenetic tree of those 296 isolates in a very basic way showing how related or unrelated different isolates are to each other. Our sample collection included 190 XDR isolates marked there in the orange, 54 MDR isolates marked in the bright green, and 52 drug-susceptible isolates marked there with the open boxes. We found in the xdr-Tb cases, the rate of HIV co-infection was 70 to 79%. And notably, we found that the xdr-Tb population was highly diverse. Specifically, that we saw xdr-Tb arise independently in 11 different RFLP strain families. And RFLP strain families, just in a very basic sense, are strain families of tuberculosis that are separated by hundreds to thousands of years of evolutionary history, suggesting that these different strains of xdr-Tb all arose independently at times in the more recent past. The majority of the isolates belong to the HP RFLP family, and the majority of the HP isolates were, again, this very important LAM4 KZN strain. We then sought to reconstruct the stepwise history of evolution of drug resistance in the XDR LAM4 KZN strain. This is a phylogenetic tree of the LAM4 KZN strain showing when each mutation arose in the past. So to take an example from CAT-G, which is a gene when mutated that confers resistance to isoniazid, I apologize for the resolution of the blow-up there. The green dot shows the node for the most recent common ancestor for all of the isolates that carry that mutation, and the date for that node, the most recent common ancestor, and when we think that mutation arose, was 1962. Similarly, for the INHA promoter region, we date that mutation at 1975 with the highest probability, 95% highest probability confidence interval between 1964 and 1983. That's essentially the confidence interval around the dating estimates. The RPOB mutation that confers resistance and marks the transition to xdr-Tb, we estimate was acquired in 1985. Then the jump to xdr-Tb involved the acquisition of 4 mutations, 2 additional RPOB mutations, a gyre-A mutation that confers resistance to fluoroquinolones, and an RRS mutation that confers kanamycin resistance. We estimate that these mutations all arose sometime between 1988 and 1998, most likely in 1993. I will highlight that our work here is consistent with some excellent prior work dating these mutations as well. Next, turning to the size of the TB bacterial population going back in time. A couple important dates here on the timeline. So 1993, if you'll remember from the last slide, that's where we date the whole genome sequence-based estimate for when xdr-Tb was fully built at 1993. Second, 2001, when the first isolate of xdr-Tb was isolated in the lab. And then 2005, the Tuberculosis outbreak. What we see is that the effective population size, the size of the bacterial population, increased 4 to 5 years before the first reported XDR isolate in 2001. We also see that this was 10 years. The population expansion occurred 10 years before the Tuberculosis outbreak. Also, the expansion in the size of the bacterial population was concurrent with an increase in overall TB incidence across South Africa. and concurrent with an increase in HIV prevalence that occurred between 1990 and 2010, as marked in the red line there. So just to underscore what we think our results say, extensively drug-resistant populations of tuberculosis expanded in terms of their population size well before the Tugeliferi outbreak, suggesting ongoing community transmission prior to detection via public health surveillance. To highlight a few limitations of our study briefly, one is that possibly some of the LAM4 KZN strains were oversampled and other strains were undersampled for a variety of reasons. Second, to be conservative about how we interpret the effective population size, and to think of this as a proxy for incidence or total number of infections and not a direct measurement of those quantities. So taken together, putting everything back in the context of our three questions. When did xdr-Tb arise in KwaZulu-Natal? We think most likely in 1993, 8 years before the first isolate was reported in the lab, and 12 years before the Tugeliferi outbreak. Second, we saw the bacterial population size expand well before 2001, suggesting ongoing transmission of this strain before detection via public health surveillance. Second, what pathogen-specific biological factors may have contributed to the emergence and spread of xdr-Tb? We found a unique set of RPOB mutations in this epidemiologically successful KZN LAM4 strain, raising the question of whether a selective advantage might be associated with additional RPOB mutations. Third, how did HIV co-infection and transmission in a high HIV prevalence setting influence the epidemiology and evolutionary history of xdr-Tb? We see a close temporal association between increasing HIV prevalence, increasing incidence of all TB cases, and the overall size of the xdr-Tb bacterial population size. Taking these things together, it's really not unreasonable to believe that HIV likely facilitated the spread of xdr-Tb. Some implications from this work. I think this comes as news to no one, and that this is work that underscores that HIV treatment is likely going to be a cornerstone for preventing further spread of xdr-Tb. Second, we need to monitor early and aggressively for drug resistance, particularly for new anti-TB medications, and arguably we should be looking for resistance to delamanid and bedaquiline now. Third, to underscore that the evolution of drug resistance happens fast, even in TB, and highlights the role that whole genome sequencing can play in the early detection of emerging drug resistance before it becomes clinically apparent or detected via public health surveillance, conventional public health surveillance. I wanted to acknowledge our collaborators here, particularly Barun Mathema, my advisor and mentor, and the rest of the TRACS team who contributed samples and lots of hard work to this project. Thanks for your time. Happy to take some questions.
Thanks, Tyler. The paper's open for questions. Can I just ask you just a few comments? It always strikes me, as I come from South Africa, that KZN is a little bit different from everywhere else. They did have a policy, I think, of more hospitalization for TB cases than other provinces. And I'm aware that the dogma is that HIV-positive patients are less infectious. Do you have any ideas on what might have driven that? Is it by putting very susceptible individuals into the same settings as others? Obviously, hospitalization in Tugeliferi was important.
Right. Yeah, so I think it's difficult maybe to say, and I think, anecdotally, that's sort of where the attention first fell, right, was co-hospitalized HIV-infected patients as a potential reservoir or initiator for this transmission. But, I think that the data on whether new infections are acquired while on treatment versus transmitted in the community suggests that, I don't know how far you can extrapolate this, but that transmission is ongoing in the community and may or may not be driven by increased hospitalization.
Thank you. On the right-hand side, a question?
Yeah, my name is Simon. I'm from Montreal University Hospital. Thanks for that. My question is, what would appear to you in a context of limited resources as a good minimal surveillance infrastructure?
Yeah, I think the answer to that question is probably changing with time. Particularly as some of the sort of next generation sequencing technologies like nanopore are coming on board, and in corollary examples in, say, Ebola or other sort of outbreak situations or epidemic situations, I think those technologies are emerging as really very useful and practical on the ground, rather than, in the lab, at the university lab, et cetera. So I think if you're looking forward about how to use genomic surveillance in this context, I think those are the tools to look to.
And maybe just complementary to that, especially for bedaquiline and these new coming drugs for which we don't have much pheno-geno correlation data, what would be like a minimal culture-based infrastructure that needs to be maintained in order to be able to foresee things happen?
Yeah, I think I think that's a really sort of difficult question, right? If you don't have a clear phenotype-genotype correlation, what exactly is the marker that you're looking for? There are certainly candidate genes for both of those, for both bedaquiline and delaminid resistance, and you could look almost agnostically, and how actionable this information would be or not, but to look just to maintain surveillance in those genes and to keep sort of a running library of what those mutations might be, and as clinical resistance emerge, you could quickly have this sort of pheno-geno correlation and act on it.
Thank you.
Thank you very much.
Thanks.
Thank you, Dana. The third presentation is from Boris Jakut Ugwe, who's an MD epidemiologist from the Bordeaux School of Public Health. And for 2 years, he's worked within the Epidemiology Research Center at ICEBED. And he'll be presenting data on the incidence of tuberculosis in the first year of antiretroviral treatment in West African HIV-infected adults.
Good afternoon, everyone. Thank you to EIS and thank you to my co-author for giving me the opportunity to present this work today, entitled Incidence of Tuberculosis in the First Year of Antiretroviral Treatment in West HIV-Infected Adults. All authors who participate in this work have no conflict of interest to declare. HIV affect about 36 million of people in the world, and 70% of this population live in sub-Saharan Africa. The burden of tuberculosis in people who live with HIV is very high, and more than 17% of co-infected people live in Africa. About 40,000% of co-infected people died, and more than 70% of deaths occur in Africa. Among people living with HIV, improvement in access to antiretroviral therapy has been associated with decrease of incidence of tuberculosis, but it remains that incidence of tuberculosis stay high in people living with HIV on treatment than in non-infected people. In order to prevent tuberculosis among this population, isoniazid preventive therapy is recommended. However, it is not implemented in West Africa. Therefore, we opted to assess the incidence of tuberculosis during the first year of antiretroviral therapy and identify associated factors in HIV-infected adults in West Africa. For this study, we used data from ID West African Collaboration Cohort, an HIV research program funded by the U.S. National Institute of Health, and we decided to select 3 HIV outpatient centers in 3 countries of West Africa, Ivory Coast, Burkina Faso, and Senegal. We included HIV patients older than 50 years who initiated ART between 2010 and 2040 without ongoing TB at ART initiation, and who have done more than at least one follow-up visit. The follow-up of this patient was considered according to the local follow-up calendar of each site. IPT was not implemented in this site. Concerning the diagnosis of tuberculosis, systematic symptom screening for active tuberculosis was done in all sites, and the diagnosis was done according to national recommendation. The experts were available since 2013 and was required when a smear was negative in patients with clinical signs of tuberculosis. The endpoint in this study was to determine incidence cases of tuberculosis defined as tuberculosis event notified less than 1 week and at least 1 year after initiating ART. We estimated true incidence of tuberculosis in our study population, and with a multivariate Poisson regression model, we estimated the adjusted incidence with associated factor. Our result. Out of 4,154 patients who started ART since 2010 in 3 sites, 3,404 had done at least one follow-up visit, and we excluded 191 patients with ongoing TB at initiation. So finally, we included in this study 3,230 patients, and we found 117 cases of tuberculosis. Baseline characteristic. We have enrolled 30% of patients in Ivory Coast, 8% in Burkina Faso, and 12% in Senegal. Our study population was mostly young female people with a median BMI of 20.6. 7% had a past TB history, and the median value of CD4 cell count was 211 cells for microliter, and the median value of hemoglobin was 11. For 2,360 patients here at risk, we found a general incidence of tuberculosis during the first year of antiretroviral therapy of 7.2 per 100 patient years. And in Ivory Coast, the incidence was 14.2 per 100 patients, and 40.42 in Burkina Faso, and 1.77 in Senegal. Now, looking at associated factor with incidence of tuberculosis. The country, sex, BMI, past TB history, CD4 count, and hemoglobin was all significantly associated with incidence of tuberculosis in people living with HIV. And as we can see in second to the last column, the risk of tuberculosis was high in patients living in Ivory Coast than patients living in Burkina Faso and Senegal. And male patients had almost 2 times more risk than female. Patients with past TB history of tuberculosis had 4 times more risk than patients without past TB history, and patients with hemoglobin less than 9 had almost 2 times more risk than patients with hemoglobin at least 11. Finally, we highlight here adjusted incidence rate of tuberculosis in the first year of treatment, corresponding to the incidence of tuberculosis in female patients from Côte d'Ivoire with a normal BMI, CD4 count greater than 500, and hemoglobin greater than 11. It corresponds to 1,420 cases per 100,000 patients at risk if we convert according to the usual unit used by WHO. So we found here an incidence rate more than 20 times higher than in general population in these three countries, even after controlling baseline difference. The associated factor that we found here were already found in 2005 in previous similar study in Ivory Coast. And we have seen adjusted incidence was 4 times high in patients from Ivory Coast, in line with the trend of incidence in the general population in this country. However, in view of the fact that we are in a core study with non-standardized procedure, we can completely exclude the hypothesis of underreporting of cases, in particular in Senegal. As a conclusion, incidence of tuberculosis remained high during the first year of antiretroviral therapy in the West African context in absence of isoniazid preventive therapy. Otherwise, the effectiveness of strategy combining ART and IPT in reducing of incidence and mortality associated with tuberculosis is in people living with HIV has been demonstrated. So it is necessary to implement IPT among patients living with HIV in West African setting, despite lower incidence rate in the general population compared to Eastern and Southern Africa population. I would like to thank these people and thank you for your attention.
Thanks, Boris. Open for questions now. I'll sneak in a comment and a bit of a question. Interestingly, I looked at a study that was carried out in 2,000 patients in Cape Town, which had a very similar CD4 count as your population. And the difference essentially was the screening for TB at the start of the study. So I think that you found 5.6% of cases. They found 16.27. But during the first year, they had much lower rates. They had, I think, 5% versus your 16%. So I think the importance is, if we're going to apply this to a population, is how you screen for TB at the baseline. So interestingly, in the South African study, they found 250 patients by screening, and they prevented 21 cases during a year of IPT. So I think we have to have the whole package, and screening is very important at the beginning of ART.
That's true.
Thanks. Any question at the back first, on the right-hand side?
Thank you, Mr. Presenter. I'm called Chigozi Darix from Uganda. Your presentation was not very clear as to whether the patients contracted TB while on ART or they had contracted it before. I would rather have it more clear if you had stratified the years in quarters, possibly first quarter, second quarter, third quarter, so that we know in which quarter of the year the patients contracted TB. As the colleague has just mentioned, it could be that people started the ART when they were already having the TB bacteria. Thank you.
The beginning, at the
thank you
front
very
on
much.
the right-hand side.
I'm Fred Semitala from Makerere University in Uganda. I think I share the same concern that, first of all, I don't know if I just missed it, but I didn't hear you telling us what time you made the diagnosis of incident TB, because we know that without sputum culture, it is, even the gene expert misses quite a number of TB cases at the beginning of antiretroviral therapy. And so it's difficult for you to attribute all the TB that you found to be incident TB without telling us exactly what time you made the diagnosis.
Thank you for this question. The diagnosis was done after the first year in treatment in ART, because we suppose that in the first week, after the first week of treatment, we suppose that in the first week of treatment, incidence can be due to an human response of inflammatory syndrome. So the diagnostic, all patients who have a tuberculosis after 1 week on treatment are considered as incidence case of tuberculosis. But before 1 week, we think that is an ongoing tuberculosis. And the time of the incidence case is we perform an Poisson regression model with offset time. That means that we took the time of following of each patient in our population study. So we estimate an adjusted incidence of tuberculosis in the first year, and we take in count the time of following of each patient.
Okay, thank you. Question over on the left at the back.
Thank you, Mr. Presenter. I'm Boris Chunga from Ivory Coast. I would like you to make a comment on the context of the diagnosis of TB in this region. Are the local contexts the same in each countries, or are there some difference in the diagnosis and the care of TB, just to have a better understanding of your result in the context? Thank you.
Please, Boris, can you
Are the
repeat?
countries different? The screening. I mean, you had a very high hazard ratio for Côte d'Ivoire compared to everywhere else. Is that explicable by a different policy?
The following of patients are different in each country, and I think that the difference in incidence was, it's possible that it's due to the different follow-up in patients. But when we see the global incidence in general population, we have the same trend in the incidence of tuberculosis. We have a low incidence in Burkina Faso than Côte d'Ivoire, and in Senegal than Côte d'Ivoire.
Thank you very much, Boris. And I will now hand over to my co-chair.
Thank you. Our next speaker is Sakai Mathabiri, who is a nurse. She's currently working as an operational research epidemiologist and interested in, like this, improving medical care to victims of sexual violence and improving health systems in low-income countries. We like your mission. Okay, so the title of the talk today is Feasibility of Using the Determined TB LAM test in HIV-infected adults in programmatic conditions.
Thank you. Good afternoon. I'm also interested in TB. Okay, so I'm going to present to you our findings on a feasibility study on using determined TB LAM in HIV-infected adults in programmatic conditions. The studies were conducted in Malawi and Mozambique. I have no conflict of interest to declare. So as we know, TB diagnosis is a challenge in low-resource countries like Malawi, and even though diagnostic tests are available, diagnostic test tools are available, they are not always accessible to the people that need them the most. Determined TB LAM is a point-of-care test which has rapid results, as you know, and is performed on urine. It has fair sensitivity, which improves with lower CD4s. So in 2015, the WHO released a policy guidance which allowed the LAM test to be used for HIV-positive people who had a low CD4 count or those who were severely ill, regardless of the CD4 count. So the feasibility study was part of multicentric prospective studies conducted in Malawi and Mozambique between 2014 and 2016. And the LAMP test was used as a rolling screening test for hospitalized HIV-positive patients in Malawi, as well as ambulatory patients with a CD4 less than 100 in Mozambique. It was also used as a diagnostic tool for ambulatory patients HIV positive suspected of TB with a CD4 less than 200. In Malawi, the study was conducted in Chiradzulu district and at the hospital inpatient department, hospital outpatient department, at 3 selected primary healthcare centers. In Mozambique, it was conducted in Chamankulo district in Maputo, in 1 primary healthcare center and what they call the CRAM. This is an intermediary level of care facility, so HIV positive patients who are very sick but not sick enough to be admitted are often seen in this place. And all of these sites are MOH sites which are supported by MSF in the field of HIV and TB. The LAMP test in these places was performed in the laboratory and in the clinical consultation rooms or in the hospital IPD. So we used mixed methods of data collection to describe the training required to perform the LAMP test, to assess the user acceptability of the LAMP test, the perceptions of the LAMP users on whether the test was easy to use or not, whether it was valuable to them, and to assess the percentage agreement between 2 different LAMP users. To estimate the turnaround time, we used the time interval from the urine request by the clinician to the time that the clinician received the actual results. And to estimate the daily workload attributed to the LAMP test, we used health center registers to see how many patients they were seeing per day. And we used supervision notes, minutes of meetings, and personal observations to assess the strengths and challenges of using the LAMP test. Our results. So for the training, it took approximately 1.5 hours in Malawi and 4 hours in Mozambique. So the training was, the participants were given the test SOP to read prior to the training. And during the training, 20 to 30 minutes were used to explain what the LAMP test was and for which patients we could use it on. And more of the time was used for the practical. The most difficult thing faced by the participants and the trainers was the correct use of the LAMP test reading card. So here I have an example of the LAMP test. This is the test strip. It has a control window and a patient window, and to read the patient result, you need to use the reference scale card. The test is only valid if the control line is there. On the reference card, we have a negative. So a negative means that there's no line that appears on the patient window. And then we have 4 different positive grades. They differ according to the intensity of the line. So grade 4 is the most intense and grade 1 is the least intense. On this slide, we are showing the places where the LAMP test was conducted. And on the top left, it was in Malawi laboratory, and on the top right, Mozambique mini laboratory. Bottom left, it was by the patient bedside in the inpatient department, and the last one was in the consultation room. So there was no extra space required to perform the LAMP test, and the extra equipment required was just the micropipette with adjustable urine volume and sterile urine container. In terms of the ease of use, all of the users found the test very easy or easy to use. The other option was difficult, so none of them found it difficult. However, some of them found it difficult to distinguish between the grade 1 or fainter than grade 1. I will explain. So if we go back to the LAMP test strip, I said there are 4 different positive grades and then the negative. But there's also an intensity which is between the grade 1 and the no line. And this intensity is called the fainter than grade 1 intensity. So if a patient line is fainter than grade 1, it is interpreted, the LAMP test is interpreted as being negative. So this is the problem that I'm trying to explain here. So the users found it tricky because if they made the wrong decision, the patient would be said to be LAMP positive when they actually don't have TB, for example, or maybe LAMP negative. And the other problem with that was faced before the study was implemented. The users were not using this reading card. So whenever a line appeared in the patient window, they would take it as a positive line. But in fact, they need to use the reference card to see if it is really positive or if it should be interpreted as negative. In Malawi, 18% of the patients, and in Mozambique, 8% of the patients were indicated to have a line fainter than grade 1. So was it really positive or negative? We don't know. However, despite this challenge, the reader agreement between two different LAMP readers was very good, both in Malawi and Mozambique. And this is the reader agreement between the test grade, for the test grade, and also for the test interpretation of whether it was positive or negative. And the kappa statistic was also very good. In terms of the workload, in the outpatient and primary healthcare centers in Malawi, they used an extra 27 minutes to perform the LAMP. This is after we calculated all the number of patients and how much it took to perform the LAMP. And this workload calculation only takes into account the time that is used for the clinical consultation. So we didn't include the time they use for other administrative work. And you should also take into account that these, for example, the 27 minutes in Malawi OPD, they include the full 25 minutes of waiting for the LAMP test reading. In real life, they actually saw other patients during those 25 minutes. So this is a top estimate of the actual workload. So in reality, they could utilize less time than this. And strength of the LAMP was that the results were rapid. They came on the same day, and this meant that patients could be started on TB treatment on that day if the LAMP was positive. And an added advantage of this was that it decreased the number of visits of the patients before a TB diagnosis was made. And in Malawi, this was really important to reduce the cost for the patient because in one case, they had to come over a period of 6 months, continuously coming before they were diagnosed with TB. And still on the rapid results, I just want to explain a little bit more. We found that the place where the LAMP was performed was very important. When it was performed at the bedside or in the clinical consultation room by the doctor or the nurse, the turnaround time for the result was actually quite slow, between 35 to 44 minutes. But when it was performed in the laboratory, it was a little bit higher, although the results still came on the same day. And we just want to put it in context of the other diagnostic tests. For the sputum microscopy and expert, the turnaround time was usually 2 days, and for the X-ray, it was 4 days. Another strength of the LAMP was that we were more likely to get LAMP test results because most of the patients were able to produce urine, or we were able to get urine from them by some other means. In contrast, as you can see, the sputum result, we didn't have so many patients. Well, it's above half, but the other patients were not able to produce sputum, and in Malawi particularly, there were logistics problems to get the sputum sample to the hospital, and then to get the result was another issue. In terms of the chest X-ray, the situation was even worse. And in Malawi, the reasons why many patients could not get an X-ray was often there was no water in the hospital or electricity for the X-ray to be done. And in some cases, there was no X-ray technician. And for the patients coming from the primary healthcare centers, there was they didn't have money for transport. It was important for them. So really we see the benefit of the LAM in comparison with the other tests. Some of the main challenges of the LAM test. The LAM is partially reliant on a CD4 count. And in Mozambique, we found that in the CRAM, there was a high demand for CD4. So they had a very high workload related to the CD4, and some patients were asked to come the following day. So this created some missed opportunities because some patients could not come. And the CD4 test result itself, the turnaround time is 2 hours. So the patients wait for 2 hours to get a CD4, and then if the CD4 is less than 200, then they get the LAM test. And then in Malawi, the test and treat policy has affected them because now they have stopped doing the CD4 tests. And we know that for some patients, we need a CD4 before we can perform the LAM. Another challenge was urine collection from very sick or unconscious patients, but we managed to overcome this by using sterile urinary catheters to collect the urine. And the problem with the reading card, I think I've also tried to explain that. In Mozambique, it was observed that some female patients were reluctant to give urine during their menses and preferred to wait until they had finished. So there could be some patient factors that we didn't really explore in this study. In conclusion, the LAM was easy to perform with results the same day. Patients could be started on treatment, and there was minimal logistics, and the workload was really not a lot. Although we have to say that the people did find it difficult to discriminate between the grade 1, less than grade 1, is it positive LAM or negative LAM. So we think that the LAM can be performed by nurses, doctors, anyone. And if these people have really a high workload, we think that it can also be task shift to less specialized staff in the health facility. And in terms of the CD4, we really think that it should be retained and prioritized for LAM-eligible patients. So I would like to thank all the people who participated in the study as well as the patients. Thank you.
Thank you very much. Just a little bit of a plug. There is a study, a randomized controlled study of LAM in hospitalized Malawian TB co-infected patients, and it's been running since 2015, and I think that the results should be presented later on this year. So that harmonizes nicely with the idea that it can be implemented, and we're waiting to see if there is a survival benefit in the same sort of setting that you're using.
Yes.
I really want to compliment you on your research approach to measuring these processes. I think this was like a model presentation for that, showing us pictures, explaining things, then explaining it wasn't the test, it was the pre-test actually that was one of the bottlenecks. So please stay in TB. It was really, really a nice presentation. Any other questions? Is everyone thinking, what am I going to do? Okay. Well, let's have a big round of applause for the current speaker, for all the speakers, and this session's now adjourned. Thank you.